go ahead.
Okay, right. So, good morning, sir, Dr. Deshmukh sir, Dr. Swaranjit sir. I invite Dr. Akshay Sharma, Principal of Ryadbara Dental College and Hospital, Mohali. I'm thankful to you, sir, for giving us this opportunity to organize this panel discussion on antimicrobial resistance in dentistry. And Dr. Ina Sharma, Dr. Ridhima Sood, Dr. Radhika Goel, and Dr. Anuva Bhardwaj. They will be the panelists. Sir, I request Dr. Akshay Sharma, sir, to please introduce and welcome our presidents and the speakers and audience.
Good morning, everyone.
Akshay sir, please.
Hello. Am I audible, ma'am?
Yes, sir.
Yes, sir. Yes, sir.
Good morning, everyone. It's an honor for Ryadbara Dental College and Hospital to conduct a panel discussion on antimicrobial resistance in dentistry in collaboration with Microbiologist Society of India. We are thankful to Dr. Arvind Deshmukh, the president of the society, and Dr. Swaranjit Singh, president of Chandigarh chapter, who invited us for this educative panel discussion on a very silent and illuminating subject. As we all know, antimicrobial resistance is one of the top global public health development threats these days, and it has contributed to almost 4.9 million deaths all over. And as per reported, 40 to 50% of the worldwide antibiotic prescriptions are unwarranted, out of which 3 to 11% accounts in for dentistry. So it is of great concern that we all should be very careful in prescribing our antibiotics to our patient. So once again, I welcome all of you. Thanks a lot. Thank you.
Thank you, sir, for the nice welcome. Because we have less time, so we would rather prefer more to focus on the discussions. I would like Dr. Swaranjit Singh, sir, to say something and give us green signal to go ahead with the panel discussion.
Hello. I'm very happy that you are doing a very, very pertinent topic today, that is AMR in dentistry. It is the need of the hour. We have to develop new antibiotics to save thousands of lives all over the world. And these antibiotics have to be very, very effective. They must act. You can please start the discussion.
Yeah, good morning, everyone. And I am Dr. Ina Sharma from Ryadbara and Dental College. And this will be really great opportunity for all of us as a panelist on this great platform, which has been given by the Microbiological Society of India and with the Chandigarh panel. And I would like to say that last year also we have done a panel discussion with the same society, and this society is a great platform and which is working very efficiently all over the India and even on the international platform to bring the awareness among the healthcare workers and even on the layman. And for this field, they are collaborating with each and every person who is dealing with even a medicine, dentistry, or even in the IT people. And so today, with the under the guidance of Dr. Swaranjit, Dr. Deshmukh, and Dr. Neena Mehta, and Dr. Akshay, our own principal, sir, we are going to have a panel discussion on a very important topic, that is antimicrobial resistance in dentistry, which is a major concern these days and becoming a global threat to all of us. So we'll be continuing this discussion, and I'll be covering further in this panel discussion. We'll be covering in this the introduction, the history of the antimicrobial resistance, the timeline when the antimicrobial has been introduced for the treatment, and then when it has become resistance to us. What are the causes of the antimicrobial resistance? That is the AMR, the mechanism behind that, the indications and the contraindications of the antibiotic prescription, and one of the most important topic, that is the antimicrobial resistance, which is still faced by the children, which will be covered by Dr. Anuva, and prevention and the guidelines which has been given by the various platforms and the WHO for the AMR, and further followed by the conclusion. Now, how all everything has been started. Now, what has come into the story, that Alexander Fleming, which we all know, has discovered the first penicillin notated, by which is by the method of the serendipity. That is when he is not that he is returning from the holiday in the Suffolk in 1928. He noticed that the fungus named a penicillin notated has contaminated his cultural plate of a Staphylococcus bacteria, which uh, which he has just accidentally discovered. And he noted that then he started growing that fungus, and he noted that wherever this fungus has been grown, these all zones has are bacteria free. Then Flamin has isolated and grew the mold in a pure culture. He found that the penicillin notatum proved extremely effective, even at a very low concentration, which is non-toxic, and which has even diluted to 800 times than the disinfectant which is used at that time for the treatment of the bacteria. Now, coming further, that the major part of the dental diseases are due to the oral biofilm, which contains a lot of the microbiota, and some conditions the antibiotics are recommended as an addition or as an adjunct to the active treatment for the dental conditions, especially in the acute infections. Oral microflora, which is present in the biofilm or in the dental plaque, is a source of the human oropharyngeal infections, and the prescriptions of the antibiotic by the practitioners are very much common, or as we can say it is an important aspect for the dental practice or even in the medical practice. Now, antibiotics, they are, which we all know, they are the life-saving drugs and that are needed to treat life-threatening conditions. Now, according to the World Health Organization guidelines 2023, antimicrobial resistance, which is known as a AMR, has occurred when the bacteria, fungi, viruses, or parasites no longer respond to antimicrobial medicines. As a result, the drug resistance antibiotics or the antimicrobial medicines become very ineffective or against the infection, and it become a challenge for a clinician or even a practicing doctor for to treat the patient and to even prevent the risk of the spreading, and it leads to the severe illness, disability, and even to the death. And it has been known by the WHO scenario that approximately like 10 millions of the death has been reached every year because of the antimicrobial resistance. And AMR, it is a natural process that happens over a time, which we all know that as there is a continuous change, genetic changes in the pathogens, and they're going to mutate, and its emergence and spread accelerated by the human activity which has been done by us. Basically, when we are changing and running actively in our lifestyle are changing, and this and then mainly we are misusing our overuse of this antimicrobial just to get an immediate result to treat, prevent, or control infections in human, animals, and even in the plants. Antimicrobial has been resistant and one of the biggest threats by the World Health Organization, and everyone knows that it is responsible for the more than the 10 million deaths each year by 250. It happens when the drug prescribed by these to treat the infection by any of the pathogens become very ineffective, or overuse and misuse of the antimicrobial has been lead to this antimicrobial resistance. And we as a dentist has been as we know that in by the 2015 scenario, which has been conducted in a study, we know that overall the in the field of the medicine 40 to 50% of the antibiotics has been prescribed in a medical field, which has and the dentists are responsible for prescribing like a 10% of all the antibiotics to the human. And it is the Alexander himself, which he stated that that in 1945, himself, when he was getting a Nobel Prize for this lecture, he warned the danger of the resistance of this antibiotic. It is his saying that it is not difficult to make microbes resistant to the penicillin in the laboratory by exposing them to the concentration which is not sufficient to kill them. Then the same thing actually happens occasionally in our own body by exposing his microbes to the non-lethal quantities of the drug and make them resistant. Now, coming to this further, as we can see that in this era, when the antibiotics has been introduced in the present era, like what we can see in this diagram, like in 1942, the beta-lactamase penicillin has been introduced to treat the various infection, and by 1967, the penicillin has become resistant for this. And then when we can see even in the vancomycin that in 1956 the vancomycin has been introduced, and by 1997 the vancomycin has become resistant to the various infection. As we can see that from the era which it has begun, that is since 1935, it has till today, that is till 2017, all the antibiotics which has been discovered has been become resistant in 2017 itself, and now presently we are in 2024. So in so many years that these all antibiotics which we are preserving, many of the pathogens or the microorganisms which are causing the infections, they are becoming a resistance to the all the antibiotics. The newly present antibiotics which has been introduced right now are, they are the pleuromethanolase, which we are definitely in a coming area within 2 or 3 years will be having again threat towards them, that they are also becoming resistant for the treatment. Coming to the mechanism of the resistance, which can broken down into the following: how the mechanism, how these antimicrobial treatment or these drugs become basically resistance is, but first of all, this is an enzyme inactivation or modification. So in what happens in enzyme inactivation or bacterism, the bacteria, they produce lot of the beta lactamase enzyme, and this beta lactamase enzyme, they break the beta lactam ring of the antibiotic. And now when they break the beta lactam ring of the antibiotic, they will prevent or they will inhibit the attachment of the antibiotic to the target site, that is a target site of the pathogen. And hence when the antibiotic is not able to attach to the target site, it will not able to kill this microorganism. Then coming to the modification of the antibiotic target site, there are the various mechanisms, but the most important mechanism which has been seen is like when the microorganism, they just add the another chemical group to the antibiotic. Now once the chemical group has been added to the antibiotic, it is not able to achieve or or attach to the target site, and hence the effectiveness of the antibiotic towards the pathogen has been decreased. Then coming further to the overproduction of the target, overproduction has been done by the pathogen when they produce lot of the proteins. A lot of the protein has been produced by the bacteria, and now what happened when the lot of protein has been produced by the target, by the bacteria, they then the target sites has been increased, and the antibiotic concentration is very less as compared to the target, and hence the effectiveness of the antibiotic has been decreased. Then further coming to the replacement of the target sites, as we know that the bacteria has a habit, or any pathogen has a habit of going on continuously mutation, and by going through the continuous genetic mutations, these bacteria, they mutate themselves, and then they are altering the target size, they are changing the target size, and hence they inhibit the attachment of the antibiotics to the pathogens or the concerned microbiota, which is going to threat for the life. Now, what are the causes for the antimicrobial resistance? As we all know that one of the most important causes of the antimicrobial resistance, especially in our country, is the over-the-counter available of the antibiotics. First of all is that there is a frequent and adequate consumption of the antibiotics. Now, what the frequent and the adequate consumption of the antibiotics, which we have as an Indian, we have a scenario that we have a habit of taking an antibiotic ourselves also, even without the prescription of the physician, or even we can say that a physician or the system has been developed like that for a small thing, even without a cultural activity, we just prescribe antibiotics. Then coming to the super fresh use of the antibiotics in all the fields, which we like, it's very important. Then even these antibiotics have been given to the cattle, poultry, and agriculture field, and from that we just intake this antibiotic resistance. And then self-taking, where I have discussed earlier also, like we over the counters, it is available, and there is no guidelines in India that antibiotics are not available without a proper prescription, and hence are taking of antibiotics which is available from the pharmacist shops and all that, and hence we keep on taking the antibiotics. Even for example, like a small cold or a flu, when there is no need of antibiotic, everyone has a habit, okay, let's go and take an antibiotic and we'll be fine within 3 or 4 days. And storing of antibiotics at home and later use it, and even not checking the expiration date before use after any antibiotic. When the person is layman and they are not aware about the side effects and not aware about the what are the ill effects of use of these antibiotics, they just pop out the antibiotics like anything. Now, antibiotic resistance, how does it occurs? Like we can very well clearly seen, it is a very easy in the diagram that a bunch of the bacteria, the red bacteria which has been shown in this, they are resistant to the antibiotic. So once the antibiotic has been given to this bunch, the bacteria which are resistant, they survive again, and then they further grow, they mutate, and they replicate, and then these further resistance bacteria, they transfer the resistance to the bacteria which are non-resistant to the genomic mutations. Now, the term superbugs, I think everyone has heard this term superbugs very much in the media, and nowadays they are coming a lot of in this new. What is the term? This is a superbug. What are these terms? This is a term basically which are given by the bacteria, by the media, basically to the bacteria, to the pathogens, the viruses, the fungi, which has been resistant to the multiple drugs. Now, these superbugs, they have been like a really important prospect, because they have become a global threat to all of us. When they are resistant to the multiple drugs, it is very difficult for a clinician, any physician, or even anyone to treat a patient who has suffered from this superbug. Now, few example of these superbugs are Staphylococcus aureus, that is MRSA. Mycobacterium tuberculosis is one of the most important, and I think everyone knows about this Mycobacterium tuberculosis, that it has become a super bug. And though our Indian government has been working on the various tuberculosis programs, but still they are continuously undergoing a genetic mutation. Then further Escherichia coli and Klebsiella pneumonia. Coming to the superbugs, they are everywhere. They are everywhere. They possibly even on you, and they can pass from one person to the another even in the healthy person. These microbes often remain on the body for a longer time, and superbugs cause infections are very difficult, and sometimes it is very important that it is very impossible for treat, and then it become a challenge for everyone, all of us, that how do we deal with the superbug. So patients who take antibiotics for a longer time or even at a higher risk for acquiring superbugs, they are just at a higher risk of acquiring these superbugs. Expensive and less effective second line antibiotics are often used to treat the superbug infection. They may take longer to work and must be given through an IV, and have a more side effects and require a more monitoring. So one should be very aware about these superbugs, and it should be taken care that we should all know that preventing a multiple drug resistance to prevent these superbugs from threatening and killing us. And thank you for my panel discussion. And I would like to invite Dr. Ridhima for further discussion and further knowledge on the various antibiotics. Dr. Ridhima, please come in.
Thank you, ma'am. So I'll be covering about what are the indications of antibiotics. So indications for antibiotics are basically in the treatment of odontogenic infections, non-odontogenic infections, prevention of focal infections, and prevention of local infections. Odontogenic infections are primarily dental caries and periodontal disease, but they can pose a potentially life-threatening scenario when they involve the deep facial spaces of the head and the neck, and they become suppurative. Local infections can be any kind of dental abscess. It can be pericoronal, periodontal, periapical abscess. Focal infections are secondary or localized infections that are spreading to the distant sites. So antibiotics are suggested in cases of prophylaxis for local as well as focal infections. They should not be used readily in all kinds of odontogenic infections. Instead of the removal of the source of the infection should be done first before prescribing any kind of antibiotics. So antibiotic prophylaxis is basically indicated in which kind of patient? In immunosuppressed patients, individuals with infective endocarditis, patients with history of cancer, patients with neurosurgical shunts, valvular heart diseases, patients with metabolic disorders like diabetes and splenectomies, hypertrophic cardiomyopathy, mitral valve prolapsed, and prosthetic heart. What is the rationale for any kind of antibiotic use? The rationale for the antibiotic use of antibiotics in any kind of dental practice is based on the postulate that any infectious disease is caused by specific microorganisms and that the concentration of antibiotics at the site of the infection should be equal to or exceeding the minimum inhibitory concentration, which can eliminate or reduce the bacterial load. So this table, it shows the antibiotics that are readily being used in dentistry. We are well aware of ampicillin, we are well aware of amoxicillin, metronidazoles, macrolides, erythromycin, azithromycin, clarithromycin, lincosamides, clindamycin, and tetracyclines. So I'll be discussing in detail about tetracyclines. Tetracyclines, basically, they are a group of broad spectrum antimicrobial agents, and they are active against gram-positive as well as gram-negative bacteria. The mechanism of action of tetracyclines is basically it interferes or blocks the protein synthesis by blocking the attachment of the charged tRNA to the P site of the peptide chain, thereby breaking the peptide chain and the amino acid sequence. This is primarily bacteriostatic in nature. The properties of tetracyclines for the management of periodontal disease are the inhibition of bone resorption, attachment of the fibroblasts and the connective tissue to the root surfaces, collagenase inhibition, and anti-inflammatory actions. Efficacy of tetracycline in the treatment of periodontal diseases in chronic periodontitis as well as we see in cases of aggressive periodontitis also. Tetracyclines are the only class of antibiotics that can achieve gingival fluid levels higher than that of the blood. So they are readily being used in treatment of periodontitis. Now coming on to the next drug, that is the sub-antimicrobial doxycycline. Sub-antimicrobial doxycycline is the term, basically it is based on the host modulation, and host modulation basically means modifying or modulating destructive or damaging aspects of the inflammatory host response that develops in the periodontal tissues as a result of chronic challenge that is presented by the subgingival bacterial plaque. Sub-antimicrobial doxycycline dose is basically a 20 milligrams dosage of doxycycline, and it has been approved by FDA as Periostat, and it is indicated as an adjunct with any kind of periodontal therapy in the treatment of chronic periodontitis.
All others are requested to please mute your phones.
The rationale for using sub-antimicrobial doxycycline as HMT in the treatment of periodontitis is that doxycycline, it basically downregulates the activity of the MMPs by a variety of synergistic action, like it stimulates the osteoblastic activity, it inhibits the osteoclastic activity, it reduces the cytokine levels that are pro-inflammatory cytokines in our body, interleukin 1, interleukin 6, and MMP8 also, and it also promotes new bone formation. We can see in this diagram, this is a diagram of showing the mechanism of action of sub-antimicrobial doxycycline dose. It has anti-MMP effect because it is chelating with zinc as well as calcium ions. It also scavenges the free radicals, free reactive oxygen species also. It is acting on the osteoclast also, promoting the osteoblastic activity, as well as it is also acting on the tumor cells. Now coming on to the next antibiotic, that is amoxicillin. Amoxicillin is basically a semi-synthetic penicillin with an extended and it has a very extended and infective spectrum. Uh, Amoxicillin, it acts against gram-negative bacteria, and it is commonly considered to be the first line of treatment in non-allergic patients who are non-allergic to penicillin. Amoxicillin can be used in combination with metronidazole, combination with clavulanic acid, as we all know, augmentin, that is widely being used by the dental practitioners. It is a broad spectrum of antibiotic that is believed to be the second most prescribed antibiotic uh, by the dentist. So, it basically acts by permeating the outer layer of the cell wall of the gram-negative bacteria, and it inhibits periplasmically located beta-lactamases. So we have already discussed, like we can give combination therapy of amoxicillin and clavulanic acid, and some practitioners also prefer to administer combination of amoxicillin and metronidazole to treat odontogenic. The standard dosage is around 500 milligrams every 8 hours or 1000 milligrams every 12 hours. But this combination also has some side effects. It can result in hepatotoxicity and it can change the orogastrointestinal normal microbiota, causing candidiasis. Coming on to the next drug, that is metronidazole. Is basically
I request all others to please mute their phones.
metronidazole. Ma'am, kindly mute your mics.
Please mute. Please, Anchal, please mute your phone.
Thank you, ma'am. So metronidazole is basically having bactericidal activity. It is acting against anaerobic microorganisms. It basically inhibits the nucleic acid synthesis, and it has antiprotozoal activity also. So this drug is commonly being prescribed at a dosage of 500 to 750 milligrams every 8 hourly. Dental practitioners should also bear in mind that metronidazole can interact with some agents such as alcohol. It can interact with warfarins. It can interact with hydantoin anticonvulsants. Now, coming on to the next drug, that is azithromycin. It is particularly a bacteriostatic antibiotic. It has great potency against gram-negative pathogens, and it is considered to be the safest among the macrolides. It is not suggested as the drug of choice for first-line treatment of endodontic infections, but it is usually prescribed as an alternative to penicillin allergic patients. The dosage is around 500 milligrams once a day for 3 days in case of therapeutic prescription, and 500 milligrams 1 hour before the oral procedure. Now, clarithromycin. Clarithromycin is also a broad spectrum drug, and it is considered to be the new generation of erythromycin. Clarithromycin is a bacterial protein synthesis inhibitory. It has basically bacterial protein synthesis inhibitory effect. It has anti-matrix metalloproteinases inhibitory action also that could fight against the intercellular pathogens by penetrating the cells. So the prescription of clarithromycin can be a logical approach for suppressing any kind of pulpal and periodontal infections. Standard dosage is around 500 milligrams orally 1 hour before the dental procedure. Clindamycin is a broad spectrum bacteriostatic antibiotic that covers both aerobic as well as anaerobic pathogens. And it is a newer generation of lincomycin. It is prescribed in cases of persistent infections, patients, and it has more efficacies in comparison with penicillin and metronidazole. Most recent studies have indicated that clindamycin might reduce the risk of dry stocket also after extraction procedures. So it is basically given as a prophylactic dose of 600 milligrams before procedure and 300 milligrams every 8 hourly, orally as well as intravenously. Now, combination therapy, we have already discussed. Combination therapy is most readily being given by the dental practitioners. So, rationale behind this treatment protocol is that it lowers the dose of a single agent. It exploits the synergistic action of two drugs against target organisms. It broadens the antimicrobial range of therapeutic regimen beyond that can be attained by single usage of antibiotics, and it can show its effect over a large number of microbiota. Disadvantages is that it increases the adverse reaction and antagonistic interactions with improperly selected antibiotics. In some antibiotics, they lead to reduction rather than increase in the antimicrobial activity. So, in a study that is done in 2005, they stated that adjunctive use of systemic antibiotic regimen with metronidazole and amoxicillin, along with therapeutic subgingival scaling, can be effective in cases of chronic periodontitis in reduction in the pocket probing depth and also improvements in the clinical attachment level. This combination, it would target a broad spectrum of periodontal pathogens. Metronidazole will be covering the anaerobes, and amoxicillin will be covering the facultative as well as the aerobic bacteria. Now, coming on to the endodontic infections. Endodontic disease is infectious, and microorganisms can they can result in pathosis of the pulp and the periapical tissues. So majority of endodontic infections, they do not require systemic antibiotic usage. When the cause of infection has been properly been managed with complete debridement of the pulp space, proper obturation is done, sealing of the pulp canal it is done, then no further use of systemic antibiotic is indicated. Now, this is a table showing the indications from the American Academy of Endodontics. And in this table, there are certain conditions in which antibiotics, adjunctive use of antibiotics are indicated, like in acute apical abscess, in immunosuppressive patients, in immunocompromised patients, acute apical abscess with any kind of systemic involvement or any kind of progressive infections, persistent infections also, like chronic exudation, which is not resolved by any kind of intracanal procedures and medications. Conditions in which antibiotic use is not indicated. These are the conditions in which the teeth are presented with necrotic pulps or radiolucency, teeth with a sinus tract formation like chronic apical abscess, pain without signs and symptoms of infection like apical periodontitis, and localized fluctuant swellings. Now, this is a table giving the overview of the antibiotics that are readily being used by the dentist for the conditions also. So, periodontal abscess, the treatment approach should be scaling and removal of the irritant and drainage of the pus, and no antibiotic coverage is required. Chronic periodontitis and gingivitis, scaling and root planing, no antibiotic coverage is required. Yes, we require antibiotic coverage in necrotizing ulcerative gingivitis with systemic complications, or in immune compromised patients, like patients who are suffering from HIV or acute necrotizing ulcerative periodontitis. Yes, we can give antibiotics, and metronidazole is the first choice of drugs. Other conditions in which we can give antibiotics are facial space infections, in which we have to firstly remove the foci of the infection through incision and drainage, and then we can give antibiotic prophylaxis. Systemically compromised patients also, with removal of foci of infection, and we can combine the antibiotic prophylaxis with that. In case of any kind of regenerative periodontal therapy with membranes and grafting, yes, the practitioner can give the antibiotics to the patient. And prior to, in case of any kind of implant surgery, single implant placement doesn't require any antibiotic prophylaxis, but multiple implant placements can, the dentist can prescribe antibiotics to the patient. So this is what are the now I'll be discussing about the factors leading to the misuse of antibiotics by the practitioners and the patients. So first is the placebo effect. The antibiotics, they neither control nor they prevent localized endodontic pathosis in patients. So patients, it basically gives a strong placebo effect to the patient if the antibiotics are given to the patient. Prevention of spread of infection. Antibiotics are believed to prevent the spread of the infection, and this belief often is a contributing factor while prescribing drugs in cases of acute apical abscess. The mainstay of the treatment for acute apical abscess is incision and drainage and proper root canal therapy. So, in such kind of infection, we can omit the use of antibiotics. So, to prevent flare-ups, also dental practitioners are also giving the precautionary measures for root canal flare-ups comprise of choosing proper instrumentation technique with minimal extrusion of the periapical debris, completion of biomechanical preparation in a single visit, and sealing of excess cavity between the visits, maintaining an aseptic environment during the root canal treatment procedure. Uh, Antibiotic prophylaxis is not required because the pulp is already necrotic and they show periapical radiolucencies. Uh, so, in such case, we can omit the use of antibiotics. Um, Moving on to the next slide. Now, fourth point is prophylaxis for patients at risk. Antibiotic prophylaxis is not right for everyone and should only be used when potential benefits outweigh the risk. So the study reported that prophylactic antibiotics that dentists prescribe are necessarily unnecessary 81% of the time to improve periapical healing and the treatment outcome also. Review of literature, it showed no association between the use of antibiotics and the root canal outcome. So clinical trials show that antibiotics are unrelated to post-treatment signs and symptoms and have no effect on the post-surgical outcomes. Also, to reduce post-operative pain, according to published data, root canal induces more frequent and more severe post-operative pain than any kind of dental operative procedure. Now, the next point is the patient may insist and the patient may expect the dentist to give him or her antibiotic prescription. So, studies they show that the patients they insist for prescription of antibiotics after any kind of root canal therapy. But we should believe that antibiotics, they are not miracle drugs and they will resolve or minimize, they will only resolve or minimize adverse post-endodontic events. When a patient is busy, patients with dental pain may come to the clinic of the patient and their dentist, and the dentist is already busy with his appointment book. And in such cases, the antibiotics are often prescribed to the patient not for their clinical benefit, but to delay the appointment or to cover the referral period. Although the guidelines they permit prescription of antibiotics if definitive treatment has to be delayed due to referral or to the specialist services, but prescribing antibiotics like this is totally unjustified and it should not be followed routinely. A poor patient cannot afford root canal treatment and doesn't want to undergo extraction. So, a poor patient mainly demands antibiotic prescription, thinking that they can save the tooth by warding off the infection. So, such practice should also be omitted in the dental practice. Now, prevalence in Indian scenario, antimicrobial resistance is being contributed by antimicrobial usage in humans, and India is ranking first among all countries of the world in total consumption of antibiotics for human use. There was a 23% increase in the volume of antibiotic retail sale from 2000 to 2010, and it is further increasing. The rate of consumption is feared to rise ever since, and these figures are threatening, and they are not surprising for India, where antibiotics are being used day in and day out. India is basically a low dentist to population ratio. It also has a low dentist to population ratio, and it is made worse by unequal distribution of available dental workforce also. So therefore, the healthcare often it shifts in the hands of the non-dental practitioners, such as informal healthcare providers. They are particularly they are available in the rural areas, and they are giving antibiotic prescriptions to the patients. And the data, it states that it is being accounted for over 90% of the prescriptions. Now, another reason is, according to a review in 2015, India was a leading country in manufacture and usage of substandard and counterfeited antimicrobial agents. And when testing was done, 39% of the agents were found to be substandard, and approximately half of the consumed antibiotic is eliminated unchanged from the body via the feces and the urine. As in India, the people have a practice of defecating in the open, and this is resulting in antimicrobial resistance because of the seepage of antibiotics into the environment via the soil and water. So I will like to end my presentation with this diagram. It is a continuous vicious circle, and it is affecting our agriculture, it is affecting our marine life, it is affecting our livestock, it is affecting our soil. So it is kind of a vicious circle. And the famous quote by scientist Felix Marty, he stated that antibiotic therapy is indiscriminately, if it is being used, may turn into a medicinal flood that temporarily cleans and heals, but ultimately it will destroy the life in itself. So I would like to invite Dr. Anuva to discuss about the indications of antibiotics in children and the side effects of antibiotics.
Thank you, Dr. Ridhima. I would like to wish everyone a very good morning. It's a lovely sunny day, and I'd like to begin my lecture about talking about the antimicrobial resistance in children and what is the role of antibiotic in our small children. So, as previously described by Dr. Ridhima, the antibiotics in dentistry for children, they can also be used for two purposes. So first is to control an oral infection, and second is to prevent bacteremia. Now, the oral infections, they can be of two types. First is an odontogenic infection, and second is a non-odontogenic infection. So an odontogenic infection is one which arises within or around the dentition, and it can initiate from the dental caries. And a non-odontogenic infection starts in the extradental structures, such as the mucosa, the glands, and the tongue. So these are the most common infections which affect the oral mucosa. Now, the difference is children is that the tissues in the children, they have a greater water proportion, and they have increased bone sponginess. So this results or facilitates the faster diffusion of infection. So that is why they require adequate dose adjustment of the prescribed medication. Another factor is that since children, a lot of these days, they are consuming sugar-rich foods. Now that contributes in the increase in the presence of microorganisms in the mouth. And also if the child keeps a deficient oral hygiene, he's not taking care of his hygiene, he's not brushing his teeth properly, not twice a day. So what can that can result in an increase in the risk of bacteremia following oral treatments. So that is why it is always advocated for children that if they want to eat any sugar-rich food, they should eat it between the meals. And the frequency of the sugar-rich food should also be decreased. They should not increase the consumption of the sugar, especially sticky foods such as toffees and caramels. They stick to the surfaces of the teeth, and they also decrease the pH of the mouth. So whenever the pH of the mouth is decreased, so that will result in demineralization of the enamel. So as long as the child keeps eating different sweets, so there is a cycle of demineralization which keeps occurring in the mouth, which will ultimately lead to caries formation. Now, there are some guidelines which have been given by American Academy of Pediatric Dentistry. So they are regarding antibiotics and when should they be prescribed. Now, according to the guidelines, it is always recommended that these antibiotics should be prescribed only when truly needed for a bacterial infection. So they should be an adjunct and not an alternative for any other intervention. So supposingly if a child has pain in his tooth and he wants to get it extracted, or he has to undergo maybe a root canal treatment, so it is always advocated that the parents should go for that treatment, should go for the intervention instead of asking for medications when it is not required. Because see, ultimately the pain will be resolved only by giving the treatment. The medication is only a temporary measure. So, like supposing the first condition is the oral wounds. So, whenever an oral wound is present, first of all, we have to evaluate whether the wound is contaminated or not. So, on evaluation, if we see that the wound is clean and it has no contamination and no foreign objects are present, so in such case, no antibiotics are required. But if the wound appears to be contaminated, it appears to have some bacterial infection, then it should be managed by systemic antibiotics only in that case. Now, second case is if there is pain, pulpitis, there is inflammation of the pulp, or maybe there is pus or sinus present in the mouth of a child. So in such case, what happens is that maybe a child is in pain. Then the treatment for pulpitis should be rendered. That means he should go for either a root canal treatment, right? Antibiotic is not indicated in such cases. See, because the bacteria can gain access to the pulpal tissue through the caries or through the exposed pulp, or maybe due to some defective restoration. So in such cases, it is better to go for the treatment rather than having antibiotics. Now there is a condition which is called as avulsion. Now avulsion is the complete displacement of the tooth outside the socket, right? So as you can see in the picture, there is the tooth is partially displaced out of the socket. So sometimes this happens in a traumatic situation. Maybe the child has fallen down somewhere, maybe he's fallen off his bike, or he was playing some sport, and the tooth has because of the impact of his injury, the tooth has come partially out of the socket. So in such cases we can recommend an antibiotic, right? Because we need to place the tooth back into the socket, right? And we need the help of some systemic antibiotics. So in such cases we mostly recommend amoxicillin because of its effectiveness against the oral flora. And supposing if the child is allergic to penicillin, then we can go for we can go for doxycycline, which is a good alternative as it exhibits anti-inflammatory and antimicrobial properties. Next conditions are like viral infections. So sometimes infections which have a viral origin, they should not be treated with antibiotics because since it is viral, so why would we need an antibiotic for that? So viral origin conditions such as acute primary hepatic gingivostomatitis. These are some conditions which can sometimes occur in the mouth of a child. So for viral infections, we don't advocate for a antibiotic. Next condition is if there is acute swelling on the face, and the origin for that is a dental origin. So if we can see that the swelling is contained, it is localized. So then we don't need an antibiotic. But supposing we see that the swelling is non-localized and it is progressive, we can see that it is spreading across the face and on both the sides of the face. It is bilateral, right? So when we start seeing systemic signs, such as maybe the child is having fever, his face is looking asymmetrical, right? He has a feeling of malaise, and he has tachycardia, and he has a difficulty in breathing. He's having some respiratory distress. So in such a condition, then we can go for a antibiotic since the child is now showing systemic involvement. So next, I want to show a chart in which there is this is actually a systemic review which was done regarding the prescribing trends of antibiotics. So this was done across many countries, and as you can see in the chart, the author and the year has been described. So according to the systemic review, Even in North Carolina, which is in USA, the most commonly prescribed drug is amoxicillin. And even there, we can see that there is a trend of overprescription of antibiotics. So even dentists over there, they are not adhering to the guidelines which have been given. And the same pattern was also observed in Jordan and in Croatia. So there was again similar overuse of antibiotics, and there was a lack of knowledge, and the diagnosis were unsure. So the dental practitioners have been prescribing a lot of antibiotics. Similarly, in Australia also, the amoxicillin has been overprescribed, and in North England as well. So I just want to give a brief description of what are the drugs that we are using in pediatric dentistry. So as earlier described by my colleague Dr. Ridhima in detail, so the same drugs, amoxicillin, we use for children as well who are not allergic, because as she described very well, they are effective against a variety of gram-positive bacteria, and they also offer gram-negative coverage, and they are effective against the oral flora. But in case if a child is allergic to amoxicillin, we can always go for doxycycline, because doxycycline is a very good alternative, and it has very good antimicrobial and anti-inflammatory properties. So these are some of the doses which we prescribe in children. See, dosages in children is always dependent on the weight of the child and the age of the child. So if the weight of the child is less than 40 kgs, right? So we go for 20 to 40 mg per kg. And if the weight of the child is more than 40, then we can go up to 45 mg. So mostly these medications are available in the form of oral suspensions, which are preferred by children, and in the form of tablets as well. So for suspension, we give 125 mg per 5 ml, and 250 mg per 5 ml is also available in the market. So whatever the preference of the child will be, if he wants to take the syrup or he wants to go for a tablet, so they are available in different forms. Another drug which can be given as an alternative is cefexime. So cefexime is a cephalosporin, and again it is available in different forms. A tablet is available in 400 mg. Chewable tablets are also available, and oral suspensions are also available in 100 mg for 5 ml, 200 mg, and for 500 mg. Another very popular combination in children is the combination of both, which is amoxicillin and clavulanic acid. So it was introduced in 1984, and with the help of a beta lactamase inhibitor, the synergistic effect of both the drugs is very effective. So the doses can be depends on the severity of the drugs, whether the infection is severe or whether it is less severe. So availability for this combination of drug is in 375 mg, and for an adult dose, if the weight is more than 40 kg of the child, we will go for full dose, that is 625 mg, which can be given every 8 hourly or every 12 hourly. So if you want to, I want to discuss something about the prescribing trends in pediatric dentistry. So if we take an overall assessment, we can see that approximately 7 to 11% of the antibiotic consumption is being done globally by the dental practitioners. And also the contribution of some pediatric dentists have been noticed, but the main contribution has been done mainly by the general physicians and the pediatricians, which form a major chunk of the antibiotic use. So what about the scenario in India? So this scenario can be understood perfectly by a study which was done by Conde et al. He did the study in 2016, and he did an important survey in which this survey was conducted on 100 dentists and 100 pediatric specialists. So the result of the study was that both of these groups, they were overprescribing antibiotics. So it was not just the general practitioners, but also the specialist doctors. And the trend of amoxicillin plus the combination was being used. And another important finding which we found was that these doctors, the doctors of both the group, they were very aware regarding the prophylaxis of antibiotics and the resistance. But there was a general lack of knowledge which was observed regarding the use of judicious use of the drug. So this was what was the finding of the study. So in a similar study which was done in the United Kingdom, they conducted in the 3 centers of the pediatric dentistry department.
अपने माइक बंद करो.
I request all the audience to please mute their phones. Dr. Nabamita, please off kar do.
Okay, thank you. So the study in the UK showed that an overuse of antibiotic was a lot. It was as high as 57%. But after intervention, the intervention of all these specialist doctors was done. So then after intervention, the percentage went down. But over a period of 10 years, there was an overuse of antibiotic prescription to all the children. So the most important factor which has been found in the systemic review is that one of the main reasons which doctors say they are also prescribing these antibiotics is because of the parental pressure as well. So there are some parents which they don't want to go for the treatment and they want to resolve the treatment by use of medications and antibiotics, because since they are very concerned for their child and they don't want the child to go undergo any pain. So they always they want to use medication as a way of resolving the pain. So it is always advocated. We always say one thing, that please go for the treatment instead for just going for unwarranted prescription. So this is also a reason, because of parental pressure. A lot of dentists have been advocating unnecessary antibiotics. So factors such as this, the lack of knowledge, unsure diagnosis, they have been attributed from this systemic review. So now coming on to the complications. What are the complications by using the overuse of drugs? So see, one of the most important one is treatment failures. So whenever we keep taking drugs in, especially the antibiotics in excess, there will always be treatment failures and recurring infections. So one thing we should remember is that, see, antibiotic resistant infections can affect anyone of any age or of any country. So if we are overusing these drugs, the infection can occur in any person. Because when the bacteria becomes resistant to these antibiotics, common infections will no longer be treatable. The recovery times will be longer, and the rate of mortality has also been shown to be increased. Right. So it has been estimated that if we don't fight this resistance, by 2050, up to 10 million people may die every year from untreatable infections. And especially older people who have a weakened immune system, they will have more tendency of developing serious bacterial infections. So we should always remember that it is the bacteria itself that has become resistant to antibiotics and not the person or the animal. It is the bacteria and it is not us, but since we are consuming the unnecessary antibiotics, we are making it resistant. One of the most important implication or the deleterious effect of the overuse of antibiotics is on the gut and on the intestinal flora. So as we keep consuming more antibiotics, the essential bacteria which is present in the gut, it will further affect the normal digestion and the absorption of food, right? And we can also have multiple nutrient deficiencies. So this is one of the major deleterious effect of the overuse of antibiotics. Another infection, which is called as MRSA, which is a methicillin-resistant Staphylococcus aureus infection. This is one of the direct infection and the consequence of the using of antibiotics. So this bacteria, it is resistant. The Staph aureus is resistant to many antibiotics such as amoxicillin, methicillin, right? So this is just a consequence that since this infection cannot be fought by all these bacteria, so it takes a longer time to leave our body. So another one thing I wanted to mention that there are some complications for the pediatric population as well. So for pediatric population, there will always be a risk of developing diabetes in children because see all the syrups which are prescribed for children, they always contain sugar. So these sugar containing medications, they will always lead to developing of diabetes. Second is that even in children, there can be a change of intestinal microbiota with a long-term effect. So even in a children, there can be digestive problems with the long use of antibiotics. The thirdly is there can be a risk of obesity as well in children. And the fourth one is that super infections such as a fungal infection with candida can also arise in children due to the overuse of antibiotics. And always, lastly, there will always be a risk of infection and allergy, especially like asthma or development of allergies and asthma can take place due to the overuse. So I would like to conclude by saying that antibiotic therapy is a double-edged sword. So we should not misuse it, and we need clearer guidelines for effective understanding of the indication of antibiotics. And I would like to end my lecture by saying that an appropriate action today can assure an effective cure for tomorrow. So thank you so much. Now I would like to call on my colleague, Dr. Radhika, to further continue this panel discussion.
Good afternoon, everyone. Before beginning, I would like to state a quote by Paul Ehrlich in 1908. Drug resistance follows the drug like a faithful shadow. So as the picture says, keeping antibiotics effectiveness is everyone's responsibility. Now, these newspaper clippings show that the menace of antibiotics is increasing and not just confined to adults, but also the babies. Almost 50% of the antibiotics are unapproved and are being rampantly sold in the markets. Therefore, it is high time we educate the mass to fight against the ticking time bomb. Coming on to the next slide, first I would like to spotlight a case study which was done by me among total of 150 dentists from various dental colleges in North India regarding the prescription pattern of antibiotics. And of these participants, majority of them prescribed antibiotics on a weekly basis, that is 72%, and 88% of the participants favor antibiotic therapy for acute oral infections, which is not needed. And astonishingly, 73.2% of the dentist prescribes antibiotics for pain, which indicated a lack of knowledge and uncertain diagnosis on prescribing antibiotics. Next, studies around the world have shown that most dentists know about antibiotic resistance, but they don't always think that they are the ones who are responsible for it. And it is not just dentists who think that. Most clinicians from different disciplines respond the way when they're asked the same question. Actually, we all need to take responsibility for antibiotic resistance and for tackling it. The Lancet Infectious Diseases Journal stated that in 2010, India consumed 13 billion units of antibiotics, which is highest in the world, and consequences of increased prevalence of antibiotic microbial resistance are best illustrated in case of neonatal sepsis. On average, 57,000 neonates die each year in India, which is also highest in the world. Recently, Ministry of Health and Welfare started Red Line campaign, which highlights antibiotics should not be dispensed and consumed without doctor's prescription. Then coming on to the ways in which dentists can prevent antibiotic resistance. First is making an accurate diagnosis, which is the foremost thing to do. Second, when prescribing an antibiotic, choose the right drug for the right dose and duration. Third is using of narrow spectrum antibiotics for simple infections rather than using broad spectrum drugs. Fourth, avoiding antibiotics for viral infections. And fifth is for empiric treatment, revising treatment regime based on patient progress or test results. Sixth, knowing the side effects and drug interactions of antibiotic before prescribing. Seventh, is teaching the patients about appropriate antibiotic use and emphasize the importance of taking antibiotics exactly as directed. Then next is the role of pharmacist. It is understandable that in India, other low and middle income countries, a significant proportion of population may not be able to afford paying a qualified practitioner, so they easily approach a pharmacist. Shet et al. Found that as high as 67% of private sector pharmacies in India dispensed antimicrobial drugs without prescriptions. The reasons cited were easy convenience, easy access, cheaper cost, availability of credit, and difficulty in getting an appointment. Sorry. Wait for a second. Then what can patients do? First is follow the doctor's advice when taking antibiotics. When possible, prevent infection through appropriate vaccination, washing the hands and children's hand regularly, for instance, after sneezing or coughing before touching other things or people. Always use antibiotics under medical prescription and not using leftovers antibiotics obtained without a prescription. Asking the pharmacist about how to dispose of the remaining medicines. Next is India is an important producer of food animals for the global market in form of meat, farmed seafood, and rise by 312% in the market is expected by 2030. Antimicrobial agents are widely used to prevent diseases in these farmed animals and to increase productivity. India is the world's fourth largest consumer of antibiotics after China, USA, and Brazil. So WHO has given few guidelines to prevent resistance. First is ensure that antibiotics given to animals include food producing and companion animals which are used to control or treat infectious diseases under veterinary supervision. Second, vaccinate animals to reduce the need for antibiotics and develop alternatives to the use of antibiotics in plants. Promote and apply good practice at all steps of production and processing of foods from animal and plant sources. Adopt sustainable systems with improved hygiene. Implement international standards for the responsible use of antibiotics and guidelines. Then, as WHO has extensively announced the alarming rise globally in resistance towards conventional antimicrobials, therefore it is urgent to search for alternatives to antibiotics with novel approaches. The first is antimicrobial photodynamic therapy. It is an emerging and non-invasive treatment method involving a photosensitizer and a low-energy laser light in the presence of oxygen and generate reactive oxygen species, basically killing the free radicals which are responsible for the bactericidal effect. It is used in adjunctive treatment in dental caries, endodontic diseases, periodontal diseases, and periimplantitis. Next is probiotics. These are the living strains of good bacteria. And in recent years, a significant number of studies and systematic reviews have been suggested showing the benefits of using probiotics as a preventive and therapeutic method for oral infections. Lactic acid bacteria over the years have been recognized as a promising antibiotic to boost the immunity and gut health also in the wound healing. Next, coming on to the antimicrobial peptides, these are also known as host defense peptides. It is an important part of the immune system. They have broad spectrum antimicrobial properties and most commonly used in the treatment of pathogen infections. They can present more than one mechanism of action simultaneously, leading to the direct killing of microorganisms, while also modulating the immune response. Having multiple mechanisms of action makes them more difficult to get resist. Then last is antimicrobial resistance is one of the most serious health hazard facing humanity. It causes 10 million deaths per year and an overall cost of $100 trillion to the global economy by 2050. So the World Antimicrobial Resistance Awareness Week, it is celebrated from 18 to 24 November every year to improve awareness and understanding of antimicrobial resistance. Over 50 stakeholders from more than 50 states in India came together to discuss the action required in states to prevent and contain AMR, a silent pandemic with severe known impacts on health, livelihood, and development. Then next is the antibiotic stewardship. It refers to coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug, which was approved by ICMR in 2017, which gives the 5 Ds, which is right diagnosis, right drug, right dose, right duration, and de-escalation for restricting high-end antibiotics and measuring antibiotic use either by days of therapy or defined daily doses, etc. So lastly, I would conclude for country like ours, the agenda should be about development without much use of chemicals in food production. It should be about prevention as we cannot afford the cost of AMR. It should also be about conserving the last resort antibiotics and managing the waste well to contain the AMR spread. Thank you all for your patience.
So, we have concluded the panel discussion, and if there is any question, we can ready to answer. Dr. Swaranjeet and Dr. Deshmukh.
I think it is a major problem these days, misuse of antibiotics. And we must see that there are other new antibiotics also coming up and being discovered. But of course, all these needs a lot of time for trials, and we should take care that it's a general trend that whatever antibiotics is available at home, sometimes even the doctors at home, when they prescribe to their family members, they will use any antibiotics which is available. So sometimes that also leads to a lot of problem later on. And the thing is that we as patient or as subjects also must know. We should not create panic among the general population because they don't know exactly when to stop antibiotic and when to restart. So sometimes the doctors tell them not to like break the course, and they do it, and they don't understand that it is not the same as any other drug, right? So general public should be made more aware. I think they are the main factors for causing a lot of antibiotic resistance more prevalent these days. So there should be more public platforms where we can make general public more aware about such things. Dr. Ina?
Yes, ma'am, Dr. Swaranjeet and Dr. Deshmukh, if there is anything else to consider. Ma'am, then we can conclude this panel discussion, and thank you for the Microbiological Society of India for giving us this platform, and we are giving this opportunity for everyone, especially in the Riyadh and Bharat group, to join with them in this collaboration on this very important topic, antibiotic resistance. And we would like to thank our worthy principal, Dr. Akshay, and especially Dr. Neena Mehta ma'am. Under her guidance, we are able to do this panel discussion. So we'd like to end this meeting, and thank you so much, everyone. All the participants, we are very thankful to all of you.
So
Dr.
let me say a few words.
Yeah, ma'am.
Swaranjeet sir, are you there? I think there is some net problem or something like that. Dr. Swaranjeet sir? Okay, just a moment. Okay. Okay, then I would like to thank first of all Dr. Deshmukh sir, who is the president of this Microbiology Society India, and Dr. Swaranjit sir, who is president of the Chandigarh chapter. He are always active in making public know more about microbiology and from different angles. I would like to thank Dr. Akshay Sharma sir, who is always motivating us to do more and more activities, academic as well as other activities. That is where we need that guidance and cooperation for making these platforms more successful. Our students, they need to know more because they are going to be the future doctors, and they need to know more about such types of misuse of antibiotics and use of antibiotics from different angles, and how they are prescribed, when to prescribe. So Dr. Ina Sharma, Dr. Ridhima, Dr. Radhika, and Dr. Anuba have very nicely, explained that antimicrobial resistance affects mechanism of resistance, the history, which was done by Dr. Ina, their enzyme inactivation modification mechanisms, and then Dr. Ridhima on different types of antibiotics and what are their roles, mechanisms, then their effects, and Dr. Nuba, who spoke on dose adjustments, guidelines for antibiotics in children, and when to recommend antibiotics, and what are the prescribing trends in pediatric dentistry, and overuse of antibiotics, how to use them wisely. So these all different aspects have been covered by these panelists. And Dr. Radhika talked about, unapproved antibiotics that are being used, lack of knowledge by some of the practitioners, and junk therapies, probiotics, antimicrobial peptides. So I think we have covered most of the things from our side. And any students who have the questions, that can always contact Radbara Dental College, or they can contact their teachers. I would love to have more such panel discussions from different angles. Dr. Akshay sir, it is very nice that you have really, given us this opportunity to speak on this topic. We had this type of panel discussion last year also. We are thankful to SS Free Polyclinic for collaborating with Microbiology Society India for making these types of events and activities more open, and inviting different institutes for such type of discussions. Thank you, sir. Thank you, all the panelists, and thank you, all the participants who have joined. Sir, a few words from your sides, Dr. Akshay sir. Akshay sir, could you hear me?
And I can hear you, ma'am. Thank you so much, ma'am. Thanks a lot. I'm thankful to you and the Microbiology Society president for this discussion. And I hope and we'll see we continue and give such discussions ahead in much more better, more frequently. Thank you, ma'am. Thanks a lot.
Thank you, sir. Thank you, sir, for giving us opportunity. And under your guidance, we have made this panel discussion successful. And I would like to congratulate you that our participant has gone to more than 100 for this panel discussion. And thank you, Nina, madam, also for this opportunity and guiding us through the panel discussion. And thank you, Dr. Swaranjit and Dr. Deshmukh for and giving this opportunity and to collaborate with this MSBI. Thank you so much, everyone.
Thank you. Thank you. Thank you. डॉक्टर इना, मैं एक बार कॉल करके देखूं कि वो कहाँ रह गए वो लोग।
हाँ जी मैम। Ma'am, there are questions coming in the chat, so we are doing that. We are giving the answers to the other
Yeah,
participants.
that's
By the
nice.
time
That's
we will be
nice.
waiting
Yeah.
for. नहीं, हमारी वीडियो हो रही है।
ये लोग कहाँ हैं? So I have taken the permission that we can leave. We can just. Dr. Ina, I have taken the permission. So you can answer the questions and then we can leave. Okay. हाँ, उस पे करता हूँ। Is it okay? Yeah. Okay. Thank you.